Good morning, everybody, and welcome to the second day of our ASPA 2021, the digital edition. First things first, just some housekeeping. You will be seeing a QR code flash on the slides, and could I invite everybody to give your feedback for yesterday's program? Secondly, for this session, we will be, if you have questions for our speakers, please click on the question tab and enter your questions directly in that column, okay? And we will be able to ask our speakers the questions that you want to know. All right, so on to the program. So good morning to everybody, and especially to our distinguished speakers and all our delegates. My name is Sharon. I'm a consultant with the Department of Anesthesia in KK Women's and Children's Hospital. Together with my co-moderators, Dr. Xiao Yu Nam and Dr. In San Ching, we will be moderating the quality track of 2021. I am really excited to introduce our first speaker, Professor Gregory Hammer. Professor Hammer is from the Stanford University School of Medicine. He is a doctor, a father, a scientist, an entrepreneur, a best-selling book author, as well as a radio personality. He is a true modern-day Renaissance man. He is going to talk to us about how we, the physician, is an important piece in the quality indicator and the science behind the biblical proverb, physician, heal thyself. Dr. Gregory Hammer, please.
My name is Dr. Greg Hammer. I am a professor of anesthesiology and also pediatrics in the Stanford University School of Medicine. My clinical practice is in pediatric intensive care and pediatric anesthesiology, including cardiac anesthesiology. And my research lab is invested in studying developmental pharmacology and immunology. And I've also written a book, which is available on Amazon, which many of you may know. It's called Gain Without Pain, the Happiness Handbook for Healthcare Professionals. And that is the basis of my perspective when it comes to personal resilience and wellness, which I will be discussing today. I have no disclosures other than the one related to the book, I suppose, that I just mentioned. What I'd like to cover today is thriving in the practice of medicine, beginning with physician wellness as a missing quality indicator, hopefully not missing any longer, but I'll talk a bit about physician burnout. What are the drivers, and therefore what are some of the remedies, as well as what the consequences or costs of physician burnout are. And I'd like to tell you a little bit about our WellMD Center at Stanford that was convened 7 or 8 years ago in response to the rising incidence of burnout in medicine. And we'll talk a little bit about how we can all become more personally resilient. As we know, those who are interested in quality discuss improved patient care at lower cost with better outcomes. What hasn't really been part of the formula for quality improvement, up till now at least, is physician wellness. Without physician wellness, we cannot have optimum quality. What is burnout? Burnout is simply emotional and physical exhaustion that is a result of chronic stress. And acute stress, as we know, may be adaptive. That is, the surge in serum epinephrine and cortisol concentrations may prepare us for fleeing from a predator, or perhaps more realistically, jumping in the swimming pool after that toddler who we heard with a splash fall into the pool. But when that stress with the epinephrine and cortisol levels that are elevated is persistent for weeks to months or even longer, it is really quite deleterious with respect to our cardiovascular system, our immune system, our sleep. And this is really dependent on our coping skills. So the better our personal resilience and our coping skills, the better we're able to withstand what would be stressful situations. But when our resilience is exhausted, then so are we. And this is really kind of a positive feedback loop. Chronic stress has a negative effect on our sleep. When we're sleep deprived, we tend to pick up sugary or fatty so-called comfort foods, and they may give us a temporary boost, but then we tend to crash, and these are not healthy. And in addition, when we're not sleeping well, we're very tired, and we tend not to exercise. And as I said, the decrement in our quality of sleep adversely affects our diet as well as our exercise, and then this is simply self-propagating. It creates more stress and more degradation of our sleep, etc. We also, when we're burned out, we have a negative attitude toward our job and others, and actually ourselves as well. The rate or incidence of physician burnout has probably been roughly stable for the last 10 years or so. Between 2011 and 2014, it dropped a bit and then went back up between 2014 and 2018. So relatively recent rates of burnout would include a prevalence of about 54% in the medical professions. Stanford has had a little bit better, a lower incidence and prevalence of burnout compared to the national average in the United States, but it also increased quite a bit between 2014 and 2018. And this is despite that in the last 10 years or so, burnout is getting attention of our administrators. Unfortunately, we really haven't been able to make much of a dent in the incidence and prevalence. Critical care is probably the field with the highest prevalence of burnout. And I can imagine several reasons for that. What are the drivers of burnout? If we start over here in the upper left-hand corner of this cartoon, we know that we're exposed to lots and lots of performance measurements. We have patient satisfaction scores associated with our practice, for example, and for those who have a clinic practice, perhaps in pain medicine or in internal medicine, patients are waiting for a longer period of time, spending less time with their physicians. And this is not the fault of the physicians. It's simply that the physicians are asked to see more patients every hour, but their clinics don't have more exam rooms and they don't have more staff to turn the rooms over. We may see something similar in the operating room. There's a lot of pressure to turn the rooms over, and if there's a gap between cases, then this has to be recorded as far as why that occurred. And I think we all in the operating room feel under the gun with regard to these metrics that are being cast upon us. We have a loss of control over our work. It's partly related to these metrics that we often cannot control, but we seem to be blamed for some of the problems associated with inefficiencies. And we have less and less control over our schedule. Inefficiencies in the practice environment, for example, we don't have enough anesthesia techs, we don't have enough orderlies to clean the operating rooms between cases, so the gaps between cases may be longer, and this results in our perhaps staying in the hospital for an additional hour or hour and a half at the end of the day. And no matter how resilient we are, we're still going to suffer the effects of burnout if we're spending much more time in the hospital than we feel is necessary. Implementation of the electronic medical records has been associated with inefficiencies as well as efficiencies, but it is a very commonly quoted driver of burnout in physician surveys, because sometimes the electronic medical record has glitches. It may stop us in our tracks. We may even have to delay starting a case because the system is down. And then, of course, our patients are sicker and sicker, and there's more stress associated with caring for patients every day in the operating room and the intensive care unit. So those are some of the drivers of burnout, and they point to some of the remedies, but what are the costs of burnout? In fact, this has been well studied. When providers are more burned out, there is an increased incidence in surgical errors. In addition, there's an increased incidence in medication errors when we're burnt out. Presumably, we're not being as careful when we're writing orders. Infections are increased, and that may well be because we don't participate in the usual anti-infectious measures, hand washing, and just general good hygiene. We cut corners when we're chronically stressed and burned out. And in fact, even mortality rates go up under conditions where the providers, physicians, and other healthcare professionals are burnt out. There are higher rates of mortality in the hospital. Another cost of burnout is that when physicians are burnt out, they leave. So physician turnover is a major problem when the prevalence of burnout is high. This slide shows a recent year at Stanford where you can see that among physicians who were not burnt out, about 10% of them leave every year. So this is just normal turnover, people retiring, people being recruited to other institutions and promoted in the process. So 10% is sort of a background rate of turnover among non-burned out physicians. But when physicians are burnt out, the incidence of departure from Stanford is about 1 in 5. So just upwards of 20% of physicians who are burnt out leave each year. And this is obviously associated with significant cost and disruption, both in the clinic and in research programs. In addition, burnout leads to significant physician bias. Residents who were more burned out scored higher on measures of racial bias. In addition, depersonalization, which is a manifestation of burnout, is associated with negative attitudes toward Blacks by non-Black students, by non-Black residents, excuse me. And those recovering from burnout had a decrease in racial bias. Another cost of burnout relates to physician suicide. In the United States, there's physician suicide at a rate of slightly more than 1 per day. I don't know what the rates are in Asia among physicians, but it's significantly higher than in the non-physician population and the population at large. So physician suicide is an awful cost of physician burnout. So we talk a lot about burnout and what the drivers are. How about some of the solutions to burnout? And as I said in the beginning, in the mid-2010s, an organization within Stanford at the medical school called WellMD was convened, and this was convened to address the rising incidence of physician burnout. And this is the rubric for professional fulfillment, which may also be physician burnout, for the WellMD Center. And you can see it's a pie cut in thirds, essentially. And the 3 important domains that define professional fulfillment, or on the other hand, burnout, are the culture in which we work, the efficiency of our practice, and personal resilience. So we can talk a little bit about these 3 domains. First of all, what about the culture? So our culture is an extremely important component of professional fulfillment. Our organizational values and actions that promote personal and professional growth, self-care, compassion for ourselves and our colleagues, as well as our patients, is extremely important. And when these elements are absent, the culture actually is negative and leads to physician burnout, or at least is a contributor. Leadership is extremely important. It was identified by more than 60% of Stanford physicians as very important with respect to improving professional satisfaction. As I said, we tried to optimize the culture of wellness at Stanford. One thing that was done was formation of this WellMD program, and we recruited a physician director from the Mayo Clinic's wellness program, Dr. Tate Shanafelt, and he has a half of his full-time equivalent. Half his job is paid for by the school in order to support his position as the physician director of WellMD. We also have a full-time administrative director, and you can see other positions that are funded by the school in the WellMD program include strategic projects director, director and associate director of scholarship and health promotion. So this is a significant investment, but extremely important in helping to build a culture of wellness in the medical school at Stanford. Beside the physician wellness or WellMD committee, Stanford has lots of wellness endeavors ongoing, including courses in mindfulness training, compassion training. There's actually a Compassion Institute at Stanford. They built a physician lounge with healthy snacks and drinks that promotes collegiality among medical staff when they have a break in the action. There's also significant discounts at nearby health clubs, yoga studios, etc. We have an annual retreat for our anesthesiology trainees to foster connectedness. They have mindfulness and meditation training as part of that, and I've participated annually in that program. And then we have a peer support committee as well, so that whenever a physician has an adverse event or simply needs to discuss clinical or other issues with a colleague, they simply contact the peer support hotline, and we put them together with somebody in their area. So this is the culture of medicine, or culture of our department as a contributor to wellness or burnout, depending on the status. The second domain of three is the efficiency of our practice. So among the important elements of practice efficiency is the empowerment of physicians to re-engineer their clinical processes and workflows, to involve the physicians in each clinical area in decisions related to, say, hiring and firing of support staff, to provide assistance with documentation. This doesn't apply so much to anesthesiology, but to clinic specialties. There are scribes that may participate in note-taking, so the physicians can maintain eye contact and focus on the patient rather than the medical record. And then our electronic medical record platform is called EPIC. And as I said, EPIC is, or whatever the EMR platform is a potential source of discontentment and frustration. So we have a rapid response help with EPIC. If somebody has a snag, there's a number to call, and there's somebody who will pick up the phone and share screens and get the problem solved. We also have one-on-one EPIC coaching. Practice efficiency is a major area of focus for 2021-22 in the WellMD program. And the third component of professional fulfillment is personal resilience. And so I'd like to talk a little bit about that. And personal resilience can be considered as a combination of physical and emotional or spiritual resilience. The three pillars of our physical well-being are sleep, exercise, and nutrition. So it's very important to practice good sleep hygiene, and that's a whole topic unto itself, but in other words, avoiding the use of screens while in or on our beds, avoiding television, using a laptop computer, etc. Not having caffeine or alcohol approximate to the time of going to sleep. Actually, caffeine has quite a long half-life of 5 to 6 hours. So if you're very sensitive to caffeine, as I am, even that 1 o'clock in the afternoon cup of coffee that may provide, let's say, upwards of 100 milligrams of caffeine, at 7 o'clock in the evening, it's as though one had a half a cup of coffee, and that has a significant caffeine level still in our bloodstream when it's time to go to sleep. Some people aren't bothered by that. They can drink an espresso or a cup of coffee and go to sleep right afterwards, but not me. So sleep hygiene is very important. Exercise, daily exercise if possible, could be just a brisk walk around the block. But I know that certainly in COVID, times when COVID was really peaking, exercise fell by the wayside for many people. And we had an expression in the United States for those who had gained significant weight, for example, 19 pounds, or let's say 8 kilos or so, but we called it the COVID-19. So exercise, even just a brisk walk in the evening, is extremely important. Ideally, more like 5 hours of vigorous exercise a week. Our nutrition is extremely important. This has been a great interest of mine since it was my primary interest of study at university, and I've maintained a strong interest in nutrition, particularly in the intensive care unit in my clinical practice, and certainly in my own life. And so eating well, I think maybe moving toward more of a plant-based diet, avoiding processed foods, lots of fruits and vegetables, stuff that we all know, but knowing and doing, unfortunately, are two different things. So when we're feeling fatigued and stressed, I think it really calls for re-upping our attention to our sleep, exercise, and nutrition. But what about the fourth component of our wellness? And really, you've all heard a lot about mindfulness. And my approach to mindfulness as a key ingredient of overall personal resilience is the GAIN method. So we can all appreciate that when we're in the present moment, we're happy. And yet we have difficulty being present. We tend to obsess over the past and the future. And I would call these times when we're thinking about things past and future adaptive versus maladaptive. So for example, it's adaptive to think about the past when it comes to having wonderful memories of times we spent with family and friends, going for great trips, hikes, etc. That's adaptive. It's adaptive actually to focus briefly on mistakes that we made so that we learn something and we don't keep repeating those mistakes. But beyond that, when we dwell on thoughts of the past, we tend to overthink those thoughts, and this brings shame and self-judgment, and we tend to judge ourselves much more harshly than we judge others. And so dwelling in the past often will lead to self-judgment and negative thoughts. And likewise with the future, it's certainly adaptive to plan to put bread on the table and adaptive to plan for happy times. But beyond that, when we overthink the future, we often generate fear and anxiety. And so if we think of the happiest times we've had in our lives, it's when we're present. We're taking a hike in the forest, we're noticing the tall trees and the light filtering through the canopy above, and we're not thinking about what happened yesterday or a list of things we have to do tomorrow. Under those circumstances, we're present and we experience happiness and bliss. So why is it that we so often are unhappy? And why do we feel fear, anxiety, shame, and self-judgment, low self-esteem? Well, we tend to fill our minds with lots and lots of thoughts of the past and the future, and this helps propagate stress, and that causes a degradation in our sleep. Our exercise and good nutrition habits tend to fall by the wayside. So how can we let go of all of these thoughts and bring our focus into the present moment where happiness lives? I mentioned the practice of mindfulness, and this is certainly something that many of us have attended to and is a source of significant reduction in burnout rates. And there are lots of randomized controlled studies of mindfulness practice and the benefits among patients, among healthcare professionals, and others. And one of my heroes, and I think a founder of mindfulness, is Dr. John Kabat-Zinn, who was at the University of Massachusetts. And he defined mindfulness as awareness that arises through paying attention on purpose in the present moment, non-judgmentally. So I think the key elements here are bringing our awareness to the present moment, what's happening right now. And this requires intention or purpose because our minds are wired to obsess and think excessively of the past and the future. So if we're going to be present, we have to have purposefulness and intention. And also dropping judgments. Our minds are constantly forming judgments of others and ourselves, of things in our environment. This is good, that is bad. And this is really not helpful to us and generates frustration and unhappiness, especially because we have a negativity bias and we tend to judge ourselves harshly. We compare ourselves to others. We make judgments about ourselves that are often negative and unfavorable. So mindfulness practice really is about being aware of what's happening in this moment, using our intention or purposefulness, and letting go of judgments. So why is it that we're not present more? Why are we not more mindful? And I think it's because our brains are hardwired in a couple of ways. And I can think of reasons why teleologically our brains may have developed this way. But two of the ways that our brains are hardwired are one, that we have a negativity bias. We tend to remember the negative and forget about the positive. And in the book, I tell stories about this, working with a resident, doing 4 difficult cases, and she did everything perfectly, put in epidural catheters, double lumen endotracheal tubes, arterial lines, did excellent anesthetic management. The patients all woke up comfortable, safe, breathing well. One of the patients, the resident couldn't get the arterial line in, so I stepped in and did that. But everything else was flawless. So she went home and had dinner with her husband, and as she prepared to go to bed, she took stock of her day. And did she remember all the things that went well? No, of course, the one thing she fixated on was the fact that she missed the arterial line, and Dr. Hammer had to come in and put the A line in. And that's just an example of our negativity bias, how we focus on the negative and tend to let all the positive stuff fall by the wayside. And the other quality that our brains have, as I mentioned, is this obsession with the past and the future. And again, these can be adaptive to a limited degree, like acute stress may be adaptive, but chronic stress is maladaptive, and excessive thoughts of the past and the future prevent us from being present and often bring fear, anxiety, shame, and negative self-judgment. So how can we learn to be more present? I think we can practice 4 important principles that I'll describe briefly, and we can talk much more about this in the workshop portion of the day. But I think there are really 4 pillars of our spiritual and emotional well-being. And if we practice purposefully, we can actually rewire the way our brains work. We can rewire our brains away from this negativity bias and from this obsession with the past and the future. And the way we learn, as all of you know, is really in small increments, but with repetition. So, if I'm giving a lecture to the residents, I try to make a limited number of points that I'd like for them to take home, because really small bites are more easily digestible than trying to present rather too much all at once. So all we have to do is make just the smallest bit of progress every day. I think we need a daily practice. We can't rely on that 2-week vacation that happens once a year, or perhaps a week off periodically, to refresh us for more than a very short period of time. We all know we come back from vacation and we feel as though the benefits of the vacation on our peace and happiness seem to disappear very quickly. So rather than relying on those kinds of events in our lives, vacations, let's have a daily practice that takes as little as 3 to 5 minutes. And I will talk a bit about this presence practice that I would call GAIN. GAIN is an acronym for gratitude, acceptance, intention, and non-judgment. I think, again, these are the 4 pillars of happiness and spiritual well-being. So GAIN is gratitude, acceptance, intention, and non-judgment. So again, in the workshop, I'd like to go over these in more detail and have you all share some important concepts of your own in these domains. But gratitude, I can tell you my personal gratitude. I was diagnosed with chronic lymphocytic leukemia about 10 years ago, and I felt very sick. And unfortunately, with CLL, treatment is often delayed because traditionally the treatment has been chemotherapy, and chemotherapy for most types of CLL is only of very limited benefit for a limited period of time. And so generally it's reserved for a period down the line when one might have a very enlarged spleen or becoming anemic, have very large lymph nodes. And so there's this watch and wait period where there's really no treatment until things progress. But I felt very sick, very fatigued, and so this was emotionally very difficult. I got myself in a clinical trial, and fast forward, I take one pill every day of an immunotherapy medication, and I'm completely well. There's no sign of CLL in my bloodstream. So it's easy for me to be grateful just for being here today, for being on the good side of the grass and being able to draw a breath right here in this moment today. So that's where my gratitude starts. And I'm sure we all have much for which to be grateful. And even our physical ailments and other maladies could certainly be much, much worse. So again, I think we all have many things for which we can be grateful, and we contemplate these during our morning game meditation. Acceptance is very important because we can't simply pretend that everything is fine and kind of have a spiritual bypass where thinking happy thoughts is just going to make us happy. I think we do have to recognize that there is pain in life as much as there is joy. And in order for us to be happy, we need to accept that pain. And I have a formula that's in the book, which is that suffering equals pain times resistance. Suffering equals pain times resistance. The pain is there, it's inevitable. For me, it's the passing of my son at the age of 29, about 4 years ago. So that is always the first pain that comes to me during my game meditation. And I know that there's nothing I can do about it, as the Serenity Prayer would have us understand. We need to discern between what we can change and what we cannot change. And we need to accept what we cannot change. And so during our game practice, we actually visualize opening our hearts and bringing this pain closer and closer until we merge with it, until it's part of our heart. It's within us. And in this way, we lower our resistance to that pain. And since suffering equals pain times resistance, when our resistance is lowered through acceptance, our suffering is diminished as well. And I think this is an extremely important domain in terms of being happy. Intention, as Dr. Kabat-Zinn intimated, is really that we need to be purposeful about how we live our lives, and even purposeful about our thoughts, because we do have ways in which our brains appear to be hardwired to be negative and also to be other than present. And so the good news is that our brains have this quality called neuroplasticity. And if we're intentional and purposeful, we can actually rewire our brains. We can actually train ourselves through taking very small steps, but on a daily basis, ideally, to think differently. And one great example of that is a program at Duke University called 3 Good Things. And what they have demonstrated in many thousands of people who have signed up for the program and taken serial quality of life surveys is that simply by thinking of, and perhaps writing down, ideally, if you're someone who can journal well, that's not me. I will think of 3 good things every evening before I go to bed. And what the investigators have shown is that simply thinking about 3 good things, plus or minus writing them down, that happen during the day results in improved sleep and more satisfaction with life. In other words, a greater degree of happiness. And this is an example of taking that negativity bias and turning it on its head, even just briefly, as we prepare to go to bed. It doesn't require any time. We can have these thoughts when we're turning down the bed sheets, for example. We simply recall 3 good things that happened during the day. And I know that before I go to sleep tonight, I will think of wonderful moments I had with my puppy, and what a beautiful day it was today at Stanford. And I'll recall sharing with all of you in Singapore and around the world uh, this time. And so I've got three good things right there. I can come up with plenty more as well. So just by using our purposefulness and our intention, we can guide our thoughts and actually rewire our brains in just little tiny bits at a time. What the investigators found with the Three Good Things program, by the way, is that even those who practiced Three Good Things for 15 days had benefits 6 months later. So they remained happier and their sleep remained improved even well after they had no longer been necessarily doing this practice every day. Finally, the end in gain is non-judgment. And this, again, is related to that our brains are always comparing things in our environment. This is good, that is bad, he's better looking than I am, I'm smarter than she is, you know, putting labels on everything and reducing things to judgments. And this is something that we do automatically. And again, maybe there was some benefit to this during our evolution. Maybe we had to decide between good and bad and act accordingly. I think nowadays, though, we're in much safer circumstances. We don't have to judge everything. We certainly don't have to judge the people around us. And unfortunately, we judge ourselves most harshly. And I think this is, again, because of our negativity bias. It's been well documented in various studies that we all tend to be much kinder to others, even just acquaintances, than we are to ourselves. We tend to judge others less harshly than we judge ourselves. But we can learn to drop these judgments altogether. And during my meditation, every morning when I do my gain contemplative meditation, I'm thinking of the Earth as seen from space in one of these beautiful NASA photographs, and that the Earth is this beautiful orb that's simply suspended in space. It's not good or bad. It doesn't have those qualities. It simply is exactly the way it is. And through this thought process, I can turn toward myself and understand that I, like the Earth, am neither good nor bad. I just simply am who I am the way I am. And there's no need for judgment, good or bad. And so this is really, I think, the essence of my approach to mindfulness and presence practice, and a practice that I think that can help all of us be more present and happier of this process of gain. So with that, we'll just review what we've discussed today. I think we discussed physician wellness, wellness being the missing quality indicator that hopefully will no longer be missing. We talked about physician burnout, the consequences of burnout, the drivers and potential remedies of burnout. We talked a little bit about the WellMD Center at Stanford that was convened to address the rising prevalence of burnout at Stanford and elsewhere. And then also the rubric at WellMD being culture of medicine, efficiency of our practice, and personal resilience. And I think really that the domains of culture and efficiency are more or less the responsibility of our leaders, of our administrative heads, department chair, etc., whereas our personal resilience is up to us. That is what we ourselves are responsible for, and if we're purposeful, we can address our resilience and increase our resilience and become happier people. And so with that, I will stop, and I look forward to the workshop phase of this program, and I'm grateful to all of you for your attention. Thank you very much.
Hello. Hi, Prof. Hammer. I think it's evening at your side. Okay, thank you so very much for that wonderful talk. It was really, really insightful and very much like what your book says. It's really to strengthen our common sense. These are things that we know what we should be doing, what's the right thing to do, but it just brings it all together so beautifully about the steps that we can take to do it. So I'm just going to jump right in with our Q&A session. And our first question comes from Professor Tai. She says that in recent times, a kindness movement has grown to bring about a culture change in the workplace. Do you have any data on whether this has brought about any improvement in mental stress in healthcare workers?
That's a wonderful question. I don't have any data. I would say that kindness is very closely related to non-judgment. And again, our minds seem to work in such a way that we're constantly comparing things in our environment, comparing others to ourselves, and often related to our negativity bias, we compare others to ourselves with somewhat of an unfavorable bent toward ourselves. And so I think that kindness toward others is related to non-judgment, because if we really drop all judgments of other people, our default then becomes kindness. I think perhaps the biggest challenge for most of us is being kind to ourselves. And this has been actually studied and shown that we're much kinder to others than we are to ourselves. And if we do the thought experiment that when we are judging ourselves negatively, which we tend to do, we can imagine that we're actually speaking to a friend. And how would we speak to that friend? And we would be much kinder to that friend than we typically are to ourselves. And that's a good kind of little mindfulness exercise, I think. So I don't have any data, but there's no question that dropping judgments of others, and in fact, even the world itself, leads to more of a happy, benevolent state. And maybe a bit difficult to study and generate data, but undoubtedly true.
Thank you, Prof. Emma. I think that is very, very, I think it's wonderful. You gave us a little practical tips on how we can actually address ourselves and giving ourselves more positivity. On the same note of negativity, this hardwired negativity that we have, Dr. Olivia actually asked, do you have any tips at an institutional level? So it's of the institution coming down negatively on what we do or the symptoms that we have. Is there any tips that you can give us?
Well, I would say go back to, I tend to relate everything to gain. Because I think these are 4 principles that are very simple. And somebody put in the chat box, noticing our breath. And let me just kind of digress for a moment and say that when we do our gain meditation, which can be as little as 3 minutes, I get up in the morning, I open my blinds. Nowadays, it's still rather dark during the work week. Nevertheless, I pull the blinds and then do my morning hygiene thing. And then I have a little meditation area myself, but we could sit anywhere comfortably. There's no particular position you have to sit in. And the first thing we do is close our eyes and kind of concentrate on relaxing our body by really noticing our breath. And I find it very useful to inhale slowly, perhaps to a slow count of 3, and then pause to a count of 3, and then release the breath without effort to a count of 4. And we do this for a few cycles, and then we begin to contemplate our gratitude and then acceptance, intention, non-judgment. Then we go back to the breath. And the breath brings us to the present moment, and it brings us to an appreciation, to a gratitude. And what's wonderful about the breath is it's always accessible to us. All we have to do is focus on it. I know a lot of times when I get tense, and I think we all do this, we sort of forget to breathe. Of course, we're still breathing, but we're often not breathing deeply and regularly and slowly. And when we slow the breath, our heart rate tends to slow, our blood pressure tends to go down. And once we associate our breathing with these gain principles, we can simply begin to notice our breath as we're walking down the hallway in the hospital, and it brings these principles right back to the fore: the gratitude, acceptance, intention, and non-judgment. So with respect to the negativity bias, if you will, of the institution, of course, the institution is just composed of people. So yes, we have to deal with not only our own negativity bias, but that of others in the workplace. And again, we can go to any of the gain elements, I think, and our breath, and begin to kind of let go of the anxiety this might bring. We can be grateful that even though there does seem to be negativity coming from various administrators and the leadership, we can be grateful that they have helped us have a practice that is a privilege. And, you know, there's a gratitude there that, in fact, we have a wonderful hospital in which to work. And just like our own well-being, of course, it's not perfect, but it could be worse. And we go to acceptance. Again, we have to discern between what we can change and what we cannot change. And so with regard to our leadership and negativity that comes from the hospital administration and maybe even clinical leadership, we have to determine whether we can have an impact on that. Can we gather our forces with our colleagues and go to the administration and make requests or even demands? Or is this likely to be futile? And if it's something we can't change, then we shift our focus to acceptance. And I see that somebody talked about acceptance, tolerance. Dr. Jacob said, excuse me, I was searching for her comment. Tolerance is as important as compassion. And really, this is all in the domain of acceptance, because when we accept what is, we accept that which we cannot change, we become tolerant and also compassionate. So again, I certainly empathize with anybody who feels anxiety and frustration with hospital leadership, right? It's a difficult job. And again, I think that we ourselves can view things negatively or not. So I think we have to take what is and determine whether we can change it. And if we can't, really focus on our own acceptance of what would otherwise be that negativity. And when we fully accept what is, the negative aspect of it sort of dissipates. It just simply is what it is.
Thank you, Professor Hammond. I think that's a very interesting viewpoint, and I think quite a different perspective than what most of us are used to. We have another question from Dr. Satish, and he asks about how the WellMD program had to adapt because of the COVID pandemic. I think because you had described the WellMD program as something where you had retreats for your residents, you had a pantry set up for them. Because of the COVID pandemic, were there many changes? Were they seeing more and more people asking for help during this pandemic?
Absolutely. I mean, of course, we physicians are just people, and life itself for all of us people is stressful at a baseline. And this is where our personal resilience comes into play. It's how do we respond to that stress? So I think that life itself is stressful. It calls upon our resilience if we're going to be content and happy. And then we have our professional lives, which adds another layer of stress. And COVID certainly has added another layer of stress. I think that, when I do the A in my gain meditation, I'm often thinking of accepting all of the pain and suffering, not of my own personally, but what's going on in the world. And during COVID, there've just been so many very sad situations. And I think we all suffer when our brothers and sisters around the world are suffering, whether our lives are deeply impacted or not. With respect to the WellMD program during COVID, of course, much of it became virtual. We who are on the WellMD committee meet every month. It's great to sit around a big conference table and have lunch and meet in person. Of course, we couldn't do that, so those meetings became virtual, but we kept meeting every month. Likewise, the residents retreat, which I think is so important for bonding of the residents and also I think demonstrating to the residents that we really care about them, that we put them up in a nice place in an area called Santa Cruz, which is close to the ocean. They get away from the hospital in September. They're just a month or two into the residency. And it's a wonderful experience for them. And I like to go and talk about mindfulness practice, among other things. So that was virtual as well. And of course, it's not the same. But I think all the residents understood it was the best we could do under the circumstances. So I think just like life everywhere during COVID, the WellMD program has had to adapt. I don't have any data. I would find it very easy to believe that we've had more individuals, physicians requesting support from our peer support program, which is part of WellMD. So I think just like in all walks of life and other professions, COVID has certainly added a layer of stress. And the WellMD program goes on and is hopefully providing resources and general support to all of the medical staff, including the trainees.
Oh, that sounds like a wonderful program, and I think none of us would not want to be in Santa Cruz having a retreat.
Yeah, we were actually the first major university medical center that had a chief wellness officer as part of our WellMD program. And I think now something like more than half of the major medical centers in the United States have a chief wellness officer, and they have some kind of wellness program. I think that we still have a more evolved program. We started early, and I think we're doing some really innovative things. But it's on the radar of the leadership in medical centers and clinics that it's really necessary to have this kind of a program for a variety of reasons.
Thank you, Professor Hepper. I think we have two more questions actually. One is from Dr. In, and he's asking, are we resorting to individual strategies to mitigate systemic gaps and deficiencies?
Well, I would go back to the WellMD rubric, that pie that is cut in thirds, at the center of which is professional fulfillment. And I don't know if this is answering the question or not, but our professional fulfillment on one hand and the degree of burnout amongst our medical staff on the other hand really depend on all three of those domains that are shown on that graphic that was created by the WellMD program. We have the culture of our department, of our medical center, of our group. We have practice efficiency, and we have personal resilience. And they're all equally important. No matter, as I said, how resilient we are, if we have a very inefficient practice and we're spending an extra hour or hour and a half every day in the hospital, in the operating room, the cases are running late because we don't have the right support staff to turn the rooms over, and the equipment is not present, and we have to, the surgeon's instruments are not ready, and all these things, they add up together. And if we're staying in the hospital for an hour, hour and a half extra every day, it doesn't matter how wonderful our culture is and how resilient we are, but if we're missing dinner with our family and missing out on our kids' activities, we're not going to be very happy. And similarly with the culture, if we have a lot of microaggressions and we have, whether it has to do with racial inequities or just the fact that the culture is such that we're criticized or thought poorly of if we ask for help, there are lots of elements to the culture. It's how do we support mothers who are on our faculty and in our residency program, and young fathers for that matter. How do we treat people? What kind of concessions do we make? What kind of support do we provide? All of these cultural elements are extremely important, and the culture and efficiency come largely from our leadership. Personal resilience is my particular interest because it's something that I can do largely myself. So I think these elements are all equally important, and they all need to be moving in a positive direction in order for the incidence and prevalence of burnout in medicine to be reduced over time. And I'm happy to say that in many programs, including ours, this is really on the radar of the administrators now.
Thank you very much, Prof. Hammer. I really agree with you that all three parts actually is important for our fulfillment in our professional state, and we can do what we can do for ourselves. Okay, thank you very much, Prof. Hammer. I'm going to now pass the time to Dr. Xiao, who will then open the panel discussion from our other three speakers.
Okay, thank you, Sharon. Thank you, Prof. Hammer. That was a really good discussion and talk. A lot of things really resonating with what I'm thinking. But for the next session, I want to bring on my co-moderator, Dr. Ying Shangqing. So maybe we could get Dr. Ying to be on stage. Hi, Shangqing. Hi. Okay, let me just introduce everybody to Dr. Ying, right? Dr. Ying is the Assistant Director of Human Factors and Systems Design here at KK Women's and Children's Hospital. And he is quite special because he pioneered the integration of human factors science into Singapore healthcare. And it's actually one of the very first few pioneer healthcare human factors specialists, So, and of course, he has worked with us with a diverse range of improvement projects, and I'm really glad he's here. And I want to start by asking Dr. Ying, I hear that you have been on a yacht recently.
We need some self-care, right? Get away from civilization for a bit, get in touch with nature, like what Gregory was highlighting.
So you were on a yacht, and did you have some self-care time?
I think just fresh air, just being out away from just a change of environment. What I would have done on an annual basis, we have gone camping. I would have gone out the wilderness, do my annual pilgrimage, let's say to the US for a conference. I would have gone to the national parks, but which ties in back to the whole point of what was being presented on Professor Gregory's Dr. Gregory's presentation, right, where you really need to take charge about your own care, your own health. You need to be mindful about what you want to do to really take care of yourself.
Yeah.
Are you taking care of yourself? I think you as the conference chair for this whole weekend. I've been enjoying myself in the sunlight, but you've been stuck here.
Yeah, I noticed. Yes. So yes. So what really resonated with me from the Professor Hammer's talk was the three good things. So I think it's the first G, gratitude, isn't it? Three good things. So I'm trying to think of three good things now. Like the technology this morning seems to be working really well, right? And then I have you as a co-moderator, which is amazing. And then I had an amazing first itinerary, and we had a great session. So yeah, I'm really grateful. So I've done my gratitude thing, but so for this session, I remember we talked about what we wanted to do for this session, right? So we said we wanted to, so our plenary has talked about those building safety cultures, right? And then now we're talking about personal resilience, and we want to kind of see how all of this is going to will impact on the front end, where people are really building safety systems in different parts of Asia. So
exactly.
Yeah.
No, and I think there's a part where we went from really high level predicting the future about where we're going to go into, culture building, continuous improvement, and we see that in action amongst our clinicians has shared just previously about continuous improvement. The Stanford Hospital has committed to hiring people to look after the wellness of their staff, right? Making sure that the concerns are addressed. And now we are really shifting as we wrap up closer to the end of the day, what it looks like to have quality on the ground.
Yeah. So we want to bring on our next three speakers. They're going to talk in fairly quick succession, and so that we can get a kind of overview on the kind of quality systems that they are experiencing in different parts of Asia, right? So we're going to have a speaker from the Philippines. We're going to have a speaker who will talk a little bit about where she is coming from in Korea. And then we're going to have a third speaker talking about systems that she's managing in India. And then we're going to come back after that to have a bit of a Q&A, a bit of a chit chat thing, so that we could get everybody involved. So people with questions also, yes, just put it on the side of your chat area, and then we will get to them when we can. So let me introduce the first speaker. Right, our first speaker is Dr. Linda Aracion from the Philippines. She's a patient safety advocate and a pediatric anesthetist. She's also the chair, safety and quality of the practice committee of the World Federation of Societies of Anesthesiologists. And she's going to give us a short talk about the kind of building blocks of a patient safety system that's experienced by herself. She trained and practiced in the Philippines. So can we welcome Dr. Aracion?
Good day, everyone. I am Erlinda Oracion from the Philippines. This session is about building quality systems. In healthcare, this goes hand in hand with patient safety. So I thought it best to tell you the story of my journey as a pediatric anesthesiologist in a government hospital in the Philippines. I have nothing to disclose. Anesthesiology is acknowledged as the leading medical specialty in addressing patient safety. Anesthesia is safe. This is what the anesthesiologist would usually tell the ASA 1 or 2 patient who is about to undergo a routine operation. Anesthesia is certainly safer than it was 20 years ago. But is it safe enough? How can we make things better? After several years of clinical, academic, administrative experience, I have developed a deep appreciation of the need for a well-structured, informative, practical, and logical documentation of the department's quality-related activities and their impact on the improvement of the organization. The catalyst for the change was the revision of the department's name to the Department of Anesthesiology and Perioperative Medicine. Why did we do this? Because anesthesia care became more complex and technological. Expansion included intensive care and engineering, attracting high caliber staff. Clinicians in anesthesiology are risk averse and interested in patient safety. Well, anesthesia is certainly safer than ever, owing to many different types of solutions to safety problems. The accomplishments in quality monitoring in anesthesiology highlight underlying characteristics of mishaps, and this suggests improvements in patient care. So we have applied these techniques: critical incident technique from aviation, analysis of closed malpractice claims, Australian incident monitoring study. And although a small sample was analyzed, maximum amount of useful information from the data was recovered. The subspecialty in pediatric anesthesia has become safer over the years. Still, somehow, some hospitals have been unable to comply with the safety advances that we have learned over the years. How then did we proceed to make anesthesia safe for children? We used solution strategies that include incorporating new technologies, standards, and guidelines, and addressing problems relating to human factors and systems issues. We know that the promulgation of practice parameters started in the 1980s, and to date, we have the basic requirements such as continuous presence of a qualified anesthetist, ECG monitoring, assessment of ventilation. And we do have updated standards such as pulse oximetry during and after anesthesia, capnography during general anesthesia. Other standards with important implications for patient safety include difficult airway management and sedation and analgesia by non-anesthesiologists. In our department, we do have perioperative checklists. We have our usual pre-anesthesia assessment, but for children, we have a pediatric anesthesia preparation checklist, which includes monitors, operating room setup, materials, and airway equipment. Our technological solutions include experts like us at real-time monitoring of patients electronically and through physical examination. We have our ECG, pulse oximetry, and capnography. We also use engineered safety devices incorporated in our machines. Airway management has improved with fiber optic laryngoscopy and laryngeal mask airway. We upgraded our armamentarium to include video laryngoscopes and fiber optic equipment. We have started our own difficult airway kit. We have our own trolley, in fact. We also have infusion pumps for pediatric fluid and blood management and infusions. Cognitive aids are also in place, as well as individualized pre-computed list of drugs. Proper labeling of medications is something we do in order to decrease medication errors. Resources are important, so we do have to practice fiscal responsibility and prioritization when budget time comes. But the most important resource is our human resource. Training our staff and professional collaboration is certainly very important. A multidisciplinary team approach and the family conference were initiated by our department for complex cases initially, until it became the standard of care for most of the patients for complex and extensive surgery. Our pediatricians have always been available during the preoperative and postoperative periods, but we thought that their presence intraoperatively would add value and improve patient care outcomes. Supervision is key to improving outcomes in training our residents to handle pediatric patients. We are always there for them and made sure that we also have age-appropriate equipment. Sedation training workshops improved care for non-operating room procedures, and our department has developed an app that improved our data collection and served as cognitive aids for our residents. Human factors and systems approach came about from the analysis of anesthesiologist tasks for the last 30 years. And we use our decision-making process by direct observation, review of videotapes of real cases, assessment of descriptions of mortality and morbidity cases, and the use of patient simulators. We have, to a certain extent, become academic anesthesiologists. We know that anesthesiologists are pioneers in developing and applying patient simulation for research and training. This pandemic has allowed us to do virtual simulations as well for our residents and colleagues in order to ensure that there are no risks to patients. We can present scenarios which are uncommon but critical in which rapid response is needed. Participants can see the results of their decisions and actions, and identical scenarios can be presented to different clinicians or teams. And this gives rise to interventions to improve safety culture and communication in the form of leadership teamwork, and behavior change. Despite low anesthesia-specific risk, anesthesia management has an important impact on perioperative risk and perioperative outcomes. Improving our quality system entails safe anesthesia practice using protocols, crisis management, training, skills development, CPD activities, and of course, evidence-based medicine. Safe anesthesia practice. The goal is to provide the highest standard of care and safety in any setting. The international standards for a safe practice of anesthesia puts forward that access to safe anesthesia is a basic human right and should be available to all patients irrespective of their ability to pay. Although anesthesiology has made important strides in improving patient safety, there is still a long way to go. But it is certainly important to have our patient safety priorities in the form of preoperative assessment, anesthesia plan, checking our monitors and machines, preparing efficient workspace, checking our backup equipment, and labeling all medications, and documentation from the preoperative to the intraoperative and postoperative phases in order to ensure monitoring of our data. Quality and patient safety in the Department of Anesthesiology and Perioperative Medicine of Rizal Medical Center recognizes that various advances made in anesthesiology are an important model for the rest of healthcare. It is a work in progress and requires long-term commitment to achieve their full promise. The desire to reach our North Star has undoubtedly blazed the trail for our growth as a premier facility for the young and the very young Filipino patient in our community. The beginning was bumpy, but certainly one from which learning comes from doing. The price of quality and patient safety is eternal vigilance. So we always tell patients that we are by their side, bringing the highest standards of knowledge, safety, care, and confidence. Remember, too, that clinical observation is the cornerstone of patient monitoring. But the best patient monitor is still the one between our ears. So let's make sure it's always switched on. Thank you for your kind attention.
Thank you, Alinda. Thank you for that very nice, concise overview of the system in Philippines. It seems to struck me that we're really talking about components of systems here, isn't it? Right? There's incident reporting, there's guidelines and standards, there's checklists. There's also human factors, and how it relates to our fallibility, like we heard this morning, and certainly here. A lot of things to unpack, but there was a really nice overview.
Yeah, and I saw a lot of examples of what we like to coin as frugal innovation. So, like what Dr. Linda was highlighting, that resources are scarce, and yet at the same time, there's all these technological solutions that we leverage for patient safety and quality. So, it'd be good to see how that is explored in the different domains in different countries. Speaking of which, our next speakers from Korea, right? Associate Professor Park Yong-hee is with the Department of Anesthesiology and Pain Medicine at the Chung-An University College of Medicine. She will talk to us about her experience building patient safety practices as she practiced in two departments of two very different complexity. Prof. Park.
Hello, my name is Yong-hee Park. First of all, it is an honor to be invited to ASPA to share my experience. I would like to talk about quality improvement and safety program in pediatric anesthesia in South Korea. I will talk about the various hospital settings where pediatric anesthesia is performed in South Korea, and about what I and the Korea Society of Pediatric Anesthesia have done for it. Children are usually vulnerable than adults. As you all know, there are lots of critical events during pediatric anesthesia. There is a famous Africa study about the incidence of severe critical events in pediatric anesthesia, which was performed in Europe. It was an observational multicenter cohort study, which was performed between 2014 to 2015. About 30,900 patients' data were collected, and the total severe critical event incidence was 5.2%. Many accidents in pediatric anesthesia often appears suddenly as a result of minor mistake or momentary reaction rather than due to their own physiological condition or surgery itself. Among them, I want to focus on human errors. In this paper, there were also types of critical events due to human mistake, like wrong dose of drug or wrong administration of drug. I want to share a case. At this time, a new pediatric surgeon came to this institution, which is that where had rarely performed pediatric surgery, especially for infants before. So, male 1 month, 1 month male patient was planned to get elective surgery, and his body weight was 3.2 kilogram. The surgery was to open inguinal hernia, and we performed general anesthesia. We used these drugs for induction agent, thiopental and fentanyl and rocuronium. At first, we tried to put laryngeal mask airway, but it didn't work well, so we changed it to endotracheal tube, and it worked. So the surgery started, and the operation was completed within less than 30 minutes. And while preparing for the reverser agent using atropine and neostigmine for extubation, we realized something. The patient received 10 times the planned dose of rocuronium. The nurse in charge thought the rocuronium, prepared rocuronium, was diluted in 10 times by previous duty to like 1 milligram per milliliter. And she administered 1.5 milliliter, but it was not diluted. As a result, 15 milligram of rocuronium was administered. The drug was not properly labeled, and the concentration was not indicated neither. How was the patient? Actually, after waiting for a while, like an hour under general anesthesia, we monitored the neuromuscular junction blockage level, and when the level got lighter, we used the revolver agent. Actually, there was no Sugammadex at that time. And thereafter, fortunately, he recovered without any special complications and discharged from the hospital. Actually, this was my experience. I worked in the largest pediatric children's hospital in South Korea, and then moved to relatively smaller institution. This hospital, there were more than 10,000 pediatric surgeries were performed per year, and there were 10 operating rooms exclusively for pediatric surgery, and most of the surgeons are operated only on children. But in this hospital, there were less than 1/3 of the number of pediatric surgeries, and pediatric surgeries were performed as a part of adult surgeries and usually performed if there is an empty operating room there. Of course, there were no medical staff that are specialized for pediatric anesthesia. See, so in the children's center, there many major surgeries, including cardiac surgeries, were performed, and also there are many devices were equipped with small pediatric size components. But in the new hospital, there was nothing that I can use. And also the intensive care, the PICU, pediatric ICU, was directly connected with the operating room. But in the new institution, there was no pediatric ICU. So we had to prepare some beds in part of the surgical ICU. Also, there was large fascinated day surgery center in Children's Hospital, but however, not all hospitals can have these facilities, including my new institution. And also, various protocols for each operation has been well established in this center. So they can do systematic anesthetic care for all the children, but it's really different from this center to this new institution. So these things I mentioned just now were not prepared in the new institution for pediatric anesthesia. So the case that I just previously introduced can be occur in this situation, but it should not be solved by blaming one or two persons, and it does not reduce number of accidents by that way. We must not rely on the competence of one person. Instead, there should be a strict or some organized system or program to ensure patient safety. So we made some checklists for pediatric anesthesia. This is a preparation table for nurses. There's some sizes for all the ages and the children, and this table is for the checklist for anesthesiologist in charge of the pediatric anesthesia. Although it is written in Korean language, it is a list of things to do before at the preparation for the pediatric anesthesia, at the reception, during induction, emergence, and so on. And we put these checklists in every operating room. In addition, the drug labeling system was established with the correct concentration written also. And we distributed this drug dose calculation program in every operating rooms. There are many of these programs, not only for computer programs, but also there are lots of these programs in apps also. And a cozy small day surgery center was set up in corner of our recovery room. At first, many medical staffs were reluctant to assume this role. However, through this step, we could make a team of medical staff dedicated to pediatric patients. So you can see some faculties and nurses here. This has enabled more professional patient care for children. Simultaneously, we created these leaflets that explain the procedure of secondary surgery and anesthesia for the patients, the parents, and it helped them to understand the procedure or process of the day surgery more. So this is the result of our QI, one of our QI activity using the leaflet. And actually this was a kind of in-hospital program, so the sample size was quite small, and so it did not show significant result in many items, but it helped to increase the understanding of the day surgery for the parents and caregivers. I've just compared two hospitals, but the reality is that many centers, in many centers, surgery and anesthesia for pediatric patients occupy a small accessory part of adults. However, even if the pediatric surgery is performed once or twice a year in some institutions, it is necessary to practice handling pediatric patients over and over to avoid these critical events in children. One of the effective methods for these kind of training is the simulation training. The Korean Society of Pediatric Anesthesia is implementing simulation workshop for those who need it. Here we use mannequins to make similar circumstances like operating room and give some scenarios like laryngospasm or hypovolemic events, which occur frequently in pediatric patients and might have later complications. In addition, participants can experience or practice skills like critical thyroidotomy and intraocular line insertion using this real chicken leg here. And those events are rarely happens, or if never happen. You can only learn from the textbook, but may be urgently needed for anesthesiologist if it happens. Through this program, we are helping clinicians to develop the ability to handle the critical events well and manage their patients with more confidence, even if they rarely encounter pediatric patients in their institutions. I'll just summarize now. The circumstances in which you will have your pediatric anesthesia practice can be different from each other. However, we cannot rely on personal experience to prevent rare but life-threatening events. Establishment of safety system may be the most important part in pediatric anesthesia. The development and implementation of such a system can be started from trivial effort during your daily practice. And I want to say that everyone can start it if the person has affection to their patients. Lastly, I would like to end this presentation by sharing the autumn scenery of Korea, in Korea. Thank you for listening.
I think it's always frustrating when I see images of overseas countries that which we could have traveled to but cannot because of COVID.
Well, I think that's going to change soon, right?
So.
You have already gone on to a lot, so I have still to. Well, we'll get there.
Mm.
What do you think about what we just heard?
It's interesting, right? I think one of the word that I wrote down was accessory. That pediatric care in certain institutions, it's not the main business, and therefore we don't have that resource or setup to care for pediatric patients safely. And it's interesting. It's great to hear what Prof Park did, right? And it's not so much like let's build an entire department solely for pediatric services, but really to use the concept, the spirit of quality improvement to build the culture, change the mindset, create awareness of the importance of caring for our pediatric patients safely. So that was my one key takeaway, and I thought was really tied in really well with where we're going with this today.
Yeah, it was interesting for me because she went from a high workload place to a place that is a smaller workload and probably less suitable or less suited for pediatric practices, and she has to build the systems in her transition. It also struck me that she brought up elements of critical incident reporting, the culture of doing that, how simulation can actually mitigate some of the workload related skill issues that we may face. She talked about QI projects and process mapping and really about just doing something simple from the ground up, which sometimes we get paralyzed because it's such a monster, right, to build this system. So I really benefit from that. But we can get to answer questions later on. So let us get to our third speaker, Dr. Rebecca Jacob. She is the anesthesia education coordinator of the Columbia Asia Hospital, yes, Whampoa Hospital, and also the Medical Advisory Council for Smile Train India since 2008, 2009. She has done a lot of work to ensure that only quality and safe surgeries are provided to the children needing cleft palate and lip surgeries for the Smile Train program. And so she's here to talk to us about her experience in building that safety and quality program in this Smile Train. So, Dr. Jacob, please.
Good morning. I am Rebecca Jacob, a member of the Medical Advisory Board of Smile Train India. Smile Train is an international children's charity providing comprehensive cleft care to children around the world. It was founded in 1999, is present over 90 countries, partnering with more than 1,100 hospitals and with over 2,100 medical professionals who supported more than 1.5 million cleft surgeries to date. It uses a sustainable partnership model to maintain a bidirectional exchange with local medical professionals. It strategically allocates resources and tries to improve access to safety and affordable surgery as well as anesthesia. SmileTrain has aimed to build this sustainable model of treating children with clefts, which involves building and improving local capacity to provide surgical care as well as a comprehensive treatment and care package that cannot be provided by short term surgical missions. Smile Train aims to train and empower local medical professionals so as to contribute to the overall safety and quality of surgical care, which will go on and on, hopefully. In India, Smile Train is the largest non government organization for the treatment of clefts. It has over 130 partner hospitals of varying sizes and affiliations situated across different states in the Indian subcontinent. As of 2021, approximately 651,000 Smile Train sponsored surgery have taken place in India. SmileTain tries to provide a standard of safe anesthesia and surgery across all 130 partner hospitals. This has been challenging considering the diverse backgrounds and facilities of our partners, from the smallest hospitals with only one operation theatre to those in medical schools. The first challenge the anesthesia group found was to create awareness of the fact that anesthesiologists play a very important role in the safety of children undergoing cleft surgeries. We had to collect the information and form a database of anesthesiologists working at various centers. Initially, the organization was surgeon centric, but now is more team inclusive in treating cleft patients from birth to adulthood. We aim for comprehensive care. Essential treatments include understanding of clefts, feeding and nutrition, surgery, dental care, ENT care, speech services, orthodontics, counseling, and support. This comprehensive approach is only possible because our model is focused on empowering local medical professionals, and we look after the children from birth to adulthood, and we are available to the group all the year round. All new partners in India must undergo strict credentialing and an accreditation process, including a detailed assessment by the Indian Medical Advisory Council. Safety and quality review by Smile Train programs. The team tends to verify pediatric experience of the cleft team, requisite staffing and equipment in the center, confirmation that audit has taken place, and a general preparedness for and adherence to safety protocol. We have a very comprehensive setup for this. The partners must complete a self-certification audit, and as of 2020, 98% of partners in India have reported having a credentialed anesthesiologist or anesthesia provider with current certification. 94% of the partners in India have also reported having an additional anesthesia provider or intensivist. We periodically send out advisories to our partner hospitals, and these advisories are issued on safety and quality concerns regarding surgery, anesthesia, and monitoring. If you look at the safety at some of these advisories, you will notice that we have said children below 2 years should be operated on before 2 p.m. We also are very particular about giving advisories about the fluid replacements, about when they should be sent for checkups, etc. Other quality initiatives include continued training of anesthesiologists by having sessions at national conferences. We hold conferences for Smile Train anesthesiologists separately, and we formed a Yahoo group for reaching out in case of emergencies. But also in case of emergencies, the partners can contact the admin, who contacts one of our senior anesthetists who would help out. Of course, it'll be virtual. Of course, it's over the phone because they're so far away. But we are available to them for emergency care. Along with regular advisories, awareness exercises are used to improve practices. We share books, equipment to improve safety. Sentinel event reporting is very, very important and mandatory in both a corrective and preventive action format. This has been very challenging as we try to convince our partners that we will subject the case in question to a fair analysis with lessons to be learned for improvement in the system, and this is not a witch hunt. Their reporting will not lead to a witch hunt. Standardizing the anesthesia notes and post-operative care documents to improve documentation is still in progress and has still proved to be a great challenge. We believe in empowerment of the team, and the emphasis is on training the nurses and technicians involved in patient care. We run workshops. We also have special modules for training of nurses initially, and then we changed this module from just training nurses to training teams of nurses and anesthesiologists from different centers using the ASPA PPLS courses as a model. Now, empowering the team attending workshops also involves providing them with study material so that they can go back home and teach others at their place of work and then pass on the news of safe anesthesia, safe care of babies, how we can improve the situation. Now, one of the things we insist on teaching them, this is just an example, is how a nurse can intervene to improve a baby's nutrition because good nutrition is important before we take up the children for surgery. We try to do some case based teaching, and you will notice that this would have more of an impact on what we are trying to teach them. On the left, you'll see the baby as he presented to us. This was in September, 2 years ago. In October, he was admitted. We changed his nutrition. We taught the mother how to feed the baby and added supplements. By October 24th, he had gained over a kg. And by February 14th of the next following year, that is a period of about 5 months, this baby was 6.4 kilograms and was fit for surgery. Showing them this helps to pass on the message that we just don't accept any child, any malnourished child for surgery. We need to optimize the child's chances for safe surgery and anesthesia. We also have provided safety equipment support. Since 2010, nearly INR 185500000 has been donated in equipment with significant investment in anesthesia workstations, pediatric ventilators, and COVID testing and support. Thank you.
That was life-changing work.
Oh yes, yes. Palate surgeries is amazingly life-changing in a very, very short period of time. Shall we invite our panelists to come on, join us? Thank you, Alinda. Thank you, Dr. Jacob. Thank you, Yong-hee. Thank you for all of those wonderful account of your journeys and your work, and it really formed a very rich substrate for us to have our discussion. I was just sharing with Shang-Ching that cleft surgeries is one of the, I don't know, at least in my very limited experience, one of the most life-changing things you see. The person go from state 1 to a much more repaired state within 30 minutes. So that's amazing. So are there any, I was just thinking, do you have any comments, listening to each other talk, account your journeys? Are there anything that it struck you?
I think we have a long way to go. We can't sit back on what we have done. We can't sit on our achievements. We have to think of what we can do further. For me, priority, you asked us earlier about prioritization. It's how do we convince all our stakeholders, the 130 partner hospitals, how do we convince them that the advisories and protocols we send are well meant and are important to improving safety and quality? Very often they think they know it all, they've got away with so much. Why should we listen to you with your protocols, your documentation? We have to spend so much time on putting pen to paper, which we don't like. How do we convince them to get all the stakeholders on the same page for safety and quality improvement?
Yes, you have a very big task because you were working with a diverse group of hospitals and systems. Does the rest have any input on how do you convince people of the need to change, of the need to organize? Any comments from
I would say,
Melinda? Yes.
yes, I'd say that quality and patient safety should really permeate every aspect of hospital operations. And when we want to pursue quality and safety, we really have to make sure that it must be so ingrained among us that it becomes invisible. So it's like the air that we breathe, it must be everywhere and yet nowhere. But of course, there's always a harder side to it. And as Rebecca said, it's really about getting the buy in of the stakeholders that makes it quite difficult. But of course, um, anything worth doing is always purchased at the price of self sacrifice. So we will go on with our jobs and try to do everything that we could.
And I think
Can I ask about
that's where the amazing thing lies, right? All three of you demonstrated that you guys successfully have changed the culture and changed the mindset of your colleagues. Um they probably started out with a mindset that they're perfectly fine. This is quality work. I don't see the issue of why we need to change, why I need to spend time in the simulation workshop. And you guys convinced them. Again, one of the questions that I would like to know is, given the vast experience that you guys had as change agents, right? What are some of the lessons learned? Because this, I don't get success all the time. You guys demonstrated success. What are some of the lessons learned in, like Alinda mentioned about getting buy-in, or even convincing folks to spend time with you in the workshops or to listen to your checklist?
are there any lessons that you have that you can share with us? Those of us who are going to embark on similar journeys.
I think one thing is to have a good relationship with your administrators. Um, I There was a question in the chat box about resources.
Hmm.
I have not had any problems with the admin when we have asked for resources which are truly required. Um, they've been very supportive to us, and now we have Smile Train India. We had earlier we answered only to New York, but now we have a very strong admin in India, and our regional admin has been good. But again, it comes down to individuals. It is the small hospitals where they don't have a PICU, like Yonghi was saying that the small hospital didn't have an intensive care unit. Well, how do you convince that anesthetist that it's time to let go of the patient and transfer to a place which has an intensive care unit? So now, when we accredit a hospital, we check one, do you have an intensive care unit? And two, if you don't, how close is the nearest intensive care unit? And do you have an MOU with them to transfer patients? And will they take care of your patients if you run into trouble? So each point has to be looked at in detail, and we have to prove to our partners that we are not witch hunting, but we are highlighting where they've gone wrong.
That is spot on. And I think you actually pointed out Prof. Yonghi's situation, right? You went from a like a huge hospital with lots of resources to a regional, smaller operations. So, how do you manage the problem with resources?
Um, actually,
It still is a
resource.
problem.
Yes, actually, resources are a big issue for me, and like softwares like expendables, like supraglottic airways, I could prepare them easily, but like expensive facility like fibroscopic, small fibroscopes or a small blade for video laryngoscope. Actually, hospital does not let us to buy that resources easily. So I have to keep emphasize the safety
yeah, to the institution, and yeah, that's kind of problem. But um, these days, actually, and the pediatric surgeries are getting more. The volume is getting higher, and now we can we can get some
Justify.
resources. Yeah, it's
Yeah.
time. We need some time, I think.
I
No, I
have
think
a question for the others. Do you have the problem we have in our country where there is this problem of hierarchy and many of the nurses feel inferior? So they're afraid to call somebody because they will be looked down upon or laughed at. And they feel that we doctors are judgmental. So one of the things I would like to do, and I have started having PPLS courses for them, is empowerment of nurses and technicians, so that at the end of the day they enjoy their work. We lose our nurses to the Middle East. Train them well, they go off to the Middle East, or they're going off to America or Australia. We must have the means of keeping our nurses and empower them with knowledge and a sense of being happy in the work they're doing.
If I
Any
may share
Yeah,
also
Linda,
about
yes.
that, really, it's a problem when you have these people who are not empowered to speak up. But it's not only about empowering them, but it's also about training them. I think part of it is really to train them how to speak up, how to say it assertively, but make it gentle assertion or respectful assertion, as we call it, because it's really not easy. There, we also have problems with hierarchy, but I think most of our problems are really with our surgeons who think that they are always way above us. In fact, to the point that even during ORMAT or OR management team meetings, I have to help the nurses speak up for themselves, or I have to help them, teach them, give them a script so that they can speak up. I know what their problem is, they always tell me, but I teach them how to do it. So over time, they have actually stood up for themselves and started talking about what they need, what they feel, and how they feel bullied. So they have to really start, but we need to train them. I think that's part of it.
It's easier in a smaller setup where you can relate to them,
That's right.
but to do it on a bigger scale, we started this setup where we train nurses. We have a module, a 2-day course, a workshop. Now we get the anesthetists from the same institution, maybe 2 anesthetists and 2 or 3 nurses who come in. So we have about 20 people who come. We train them. One day we tell the anesthetist in the sentinel events, this is the way you should be safe and careful. We give them modules to teach the nurses, and the next day, those anesthetists teach the nurses. So they go back to their own institutions as a team, so that the team can stand up to the surgeons.
Yeah, we I think in KK and certainly in SingHealth and NHG as well, there has been systematic programs to teach people how to speak up, right, or how to do team speaks, right. One of the lessons that we learned in KK was also you have to teach people how to listen. So the leadership has to have training on how to react when someone speak up to you. So I think it cuts both ways, and it's a big cultural transformation, which we're talking about culture, right? And that's going to be really powerful. I think Dr. Tai has just asked a question about storytelling. Commander, storytelling is a useful technique to engage hearts and minds. Have you had any experiences in this area that you can share about, yes, any stories, using stories to engage, to change people's mind? Have you had any experience doing so?
Um, I've had experiences in private hospitals. Of course, it's easier to do it in private hospitals because they have the resources. But in terms of storytelling, what we have done is actually put all the quality improvement projects and put them up on posters and talk about, like having, um, I keep forgetting. I think it's called the Gamba Walk. So you have posters in every area, and then there's somebody talking about their own what they have done in terms of quality improvement. So it's a form of storytelling. Storytelling. I mean, in the same manner that I think this is the way I wanted to do it when I shared my quality experience. I wanted to tell you the story. It was not easy because the airway equipment alone, it took me over 10 years to acquire that difficult airway system for our institution.
Yeah.
It's like I told you about the clinical cases. We have the picture of the child who needed the nutrition. If you can present a case and let them discuss it, when we have our workshops for the nurses and anesthetists, we give them cases. Even if it's a sentinel event, we don't mention where it happened or who it happened to, but we make it a case, a story, and let them comment about it, let them talk about it, let them decide what is the best way to deal with it.
So
So I
I have a story. I have a story to tell about. We brought it back to the topic about speaking up, and it's a two-way communication where it's not just about empowering the nurses to say the right things at the right time. It's really getting the opposing the person listening to understand the importance of listening and recognizing this person is actually speaking out, raising the concern, right? Rather than whether that you're shared about how surgeons can be a bit tricky. Rather than showing data to my surgeon about this behavior, we just mentioned like it just takes one bad behavior from a senior surgeon and no one's going to tell you anything, right? The simple power of storytelling over was more powerful in changing mindsets than data. Are you seeing that as well in your organization, that while data is important, is really how you engage through stories that change mindsets and sets culture?
Yeah, I used to think that stories are data with a soul.
Huh?
So you can combine a story with data, then you get, it's much more powerful. And I certainly
before
think,
we wind
he's,
up, I have one little request. In the morning plenary, at the end of it, you mentioned that NSG there's a book called Building Home for.
yes, I will send you
Could
the,
you please put that up on the uh, WhatsApp
yes,
group so that we can
yes,
access?
I've gotten the clearance from Prof. Tai. It's a wonderful read. So I will share with you the link. So before we wrap up, I want to pose everybody a question. So this question is about if there was a QI genie, right, who would say, I'm going to give you one wish, right, and you can have anything in your journey that you want, then what will you ask for? Okay, so we're just going to go quickly around the table. So maybe we start with Yongki. If there's one thing that you could have, what would you ask for?
I want more people that are interested in pediatric anesthesia. So actually, our team in my institution getting larger, and also our pediatric uh, society is will grow. That's my
Okay, so you
wish.
want more people,
Yeah.
a bigger team, right?
Yes.
Yes. Okay, thank you. What about Dr. Jacobs? What is your wish?
Our surgeons have what we call the SPX, which they have to upload their surgery as well as how they're dealing with the patient. I have been fighting for the last 5 years for the anesthetist to upload their documentation on the STX so that we can
Okay.
check back and then maybe improve our um, anesthesia and our care if only the anesthetist will upload their documentation.
Okay, so you want a better data management system, a better reporting system,
And transparency.
and transparency. Okay. Now we have 1 more minute. Yes, Alinda, you get the last
I
one.
want a strong organizational culture with a committed leadership, because no matter what change you do, if this is not available to you, then any change will become short lived. So I need it for sustainability of any change that we do in quality.
That's great.
Yeah,
So
yeah.
you're asking for culture, you're asking for leadership. Yes, these are all important and essential components of our safety system. So I think we have run out of time. There's so much to unpack. I wish we had more time. And I thank you all of you, for your time and your energy and the passion that you have. And I would really want to have more opportunities to connect with you again in the future. And I will send you those links of the wonderful NSG blueprint. And thanks, Shang-Chi, for joining me, co-moderating this. I had a great time. I hope you had too. Thank you very much. Thank you.
Thank you.
Thank you.
Thank you. Okay. So I'm just going to, we have reached the end of this session. Right on.